Welcome to the Posture Dojo podcast. My name is Sam Miller. We are here on a postural transformation journey, sharing stories from my own postural transformation and recovery from an 85-degree kyphoscoliosis, and speaking with experts in various fields from breath to movement to exercise and to surgery. Today on the podcast, we have Dr. Arun from the Paley Institute, an orthopedic surgeon. We are going to have a very serious, in-depth conversation about the human body and what potentials we have when we're faced with these postural challenges. So, Dr. Arun, welcome to the podcast.
Hey, glad to be here. You're doing some really amazing stuff, and it's been fun to watch the videos that you post and speak about. Congratulate you on all the work you've done.
Thank you. I appreciate that. And I guess to give some context here to where the last time I spoke to an orthopedic surgeon about my spinal, I guess I was 18, and I had a very severe, classified as a very severe 85-degree kyphoscoliosis from the T10. And the consideration was, are you a candidate for surgery? I had function. I had some pains and aches as that structure was setting in when my body was getting used to all of that imbalance going on. But the surgeon made the decision that it was too risky and that going through that was probably not worth it because it was primarily aesthetic at that point because I had that function, and just because of the severity, I wasn't a candidate for surgery. And after that meeting, I really had to sunk in. I was, okay, you got to live with it. And I think there's a lot of people out there who are they'll beat on surgery quite a bit. I think surgery has its place. What I would love to see and explore and understand more is why, when that decision is made that someone isn't eligible for a surgery, why isn't there more support in the system to guide people through these maybe less invasive procedures as well, and giving people these basics around the breath work and holistic alternative methods?
Yeah,
that's you're familiar with.
Yeah, I'm very familiar with it, and I'm a big believer in it, and I think we're getting better at it. When I was in training, even before that, the whole idea of authoritative knowledge came from the surgeon or the doctor, and what they say goes. And there's no second opinion, there's no second options, there's nothing else. The doctor said you need surgery, you need surgery. That's how it goes. But there's been a huge shift in that, and I've seen it. I'm not that old, and I haven't been doing this for that long. But and even in my own clinics, and when I see patients, every single time, regardless if it's a 5-degree curve or if it's a 90-degree curve, they get the same outlooks and same treatment algorithms. And then it ends up being the patient and the family's decision. I'm not treating cancer here. I'm not treating a heart attack that's a life-threatening situation. So there are many options, and I totally agree with you that there should be even more, but we're getting better at it, no doubt about it.
And is there are less invasive options are usually the Schroth breathing and the brace? Those seem to be the ones that are surgery. Walk me through because on this podcast we have most people who are past that kind of adolescent years when they're eligible for surgery. Maybe give us an update on what is the current addressing towards kyphosis and scoliosis, especially considering I went through that system 20 years ago, and I know that there's new stuff coming out. So what's the current best practice treatment scenarios going on right now?
Yeah, so I take care of a lot of, as you mentioned, young adolescent idiopathic scoliosis patients, but I also see a fair number of 20 to 30-year-olds who were diagnosed with scoliosis or kyphosis and either didn't choose surgery when they were younger or the curve progressed as they got older. A fair bit of experience taking care of both, but the treatment algorithms typically goes, like you said, you can do the Schroth or bracing. And that's typically indicated for someone with growth remaining, right? Especially the bracing, because that's how the brace is supposed to work, is that it modulates the growth as they grow. And as far as the Schroth therapy, I'll just use the term Schroth to encompass the scoliosis-specific exercises. I don't want to, it's a colloquial term we all use to group all of it together, but it, I think, is an option even into adulthood. And I actually saw a patient last week who was 45 years old, had an 85-degree scoliosis and double major, so thoracic and lumbar curve. And she is happy as can be. She has no issues. She's had 3 kids. And she says, I've been doing Schroth for the last 5 years and I love it. She knows it's not going to make my curve better. And she knows it may get worse, but it makes me feel good. It makes me hold my body in a better position. And they treat me in a way where I feel good about the body I have and the way I stand and function. So I think it has a role even past the adolescent stages. I think it has a role even past the early 20s and ages. And then, of course, once you're past that threshold of not being able to tolerate the Schroth therapy, or you have clear progression of the scoliosis, or the pain or neurological symptoms starts getting in the way. And then one big thing we never used to speak about, but are understanding more and more, is cardiopulmonary function. So I've taken care of some syndromic patients as well with various conditions where they have congenital fusions, and we've seen into early adulthood that it creates things like pulmonary hypertension and valve regurgitation issues, especially the mitral valve. And those things aren't, in my opinion, reversible regardless of what you do because they're congenital fusions. And for those patients, surgery is the only way, and you really have to bring the chest wall back to expand the lung to allow them to function and continue and live without long-term sequelae of cardiovascular compromise, really.
There's these congenital conditions, there's fusions where you're really dealing with a structure. If you're looking to get serious change, surgery is one of the top options. At what age this idea of can I fix it is probably one of the most burning questions that I get people. I know, correct me if I'm wrong, around 20 to 22 is when the heal, and I'm not sure if that's technically correct. Around that 2022 is when our bones are in place. And that's what happened at that 18 until about 33 for me, when because I wasn't given this empowerment. It was always kind of like this alternative stuff that you can try. I just dabbled in that stuff. I just ignored it. I just lived with it until my hip flexors, my psoas was so tight, the imbalances higher up had crushed my midsection. My immune system started shutting down, lymphatic system, my digestion issues. I got diagnosed with IBS and I got antibiotics. I was like, no, this was like a physical infrastructure issue that was just choking me out from the inside. And that's 5 or 6 years ago when I really started, okay, what can I do? With this breathing, with this exercise, with these movements, with this elongation, what can I actually do here? And during that corrective process, I'm learning Schroth breathing and that bodybuilding, essentially, I felt these clicks, and I still do feel these clicks into place. And I know there's 2 types of gains that we can really go for. We have our spinal gains and our postural gains, right? So I felt like I've been correcting that spinal gains, but just to manage expectations for people from 20 to 30 to 40, obviously, the younger you are, the more malleable you are. But at what age is spinal gains?
Yeah, I think it's very different for everybody. The science says that we look at hand bone ages, for example, to see how much growth a child has remaining. The science tells us somewhere for boys around that 18 to 22 mark, and a little younger for girls is when the malleability goes away. But I don't totally believe that to be true. I think there's more work to be done. And I've seen it anecdotally. I don't have research to back it up per se. We don't totally understand scoliosis. I don't think we understand it well at all. We know that the spine curves, and after a certain age, that bracing doesn't work or tethering surgery doesn't work, and you need a fusion or it continues getting worse. That's what we've been teaching people forever, right? And I don't think that's true. And I've seen it changing directly in front of my eyes. And after that 20-ish mark, typically is when that rigidity really goes up. But I think, like you said, with the idea of breathing exercise and elongation, even if biology seems to suggest, I think there's a role for it.
I agree, and I'm wondering what you're seeing in terms of this conventional algorithm. The treatment algorithm it's really been more about the spine. Do you see it starting to include any more like the psychosomatic or psychosocial somatic strategy, right? Which is the brain and our social relationship, our reflection to the environment that we're living in as well. Are these things starting to come into the scene?
1,000%. And you can go on PubMed and start seeing how many more people talk about these things. And I bring it up in almost every clinic visit with these patients because it's easy for a doctor to say, hey, you have a 45-degree curve, you're going to need surgery at some point in your life, or wear this brace. But you got to think about everything else that happens. And usually these are teenage girls, right? They're in high school. Can you imagine the social implications of wearing a brace to school when things are already hard enough? Or being out of school for 2 weeks to a month to recover from surgery when you're in this peak point of your life where you're supposed to be excelling and thinking about college and doing sports? We often encourage patients to not only seek social support from others who have gone through this process, whether surgery or not, and we have a list of patients who accepted this and who are willing and happy to talk to patients who are considering the various treatment options. But I think seeking help from a mental health professional, whether it's a licensed social worker, a psychologist, or a psychiatrist, I think it cannot be overstated how important that is. It's very easy for me to fix a scoliosis and say goodbye, have a good life, but I don't see the things that happen at home all the time.
Mhm. Yeah, that's amazing, and I'm excited to know there are surgeons like you who are, ready for this kind of more holistic approach that I think it does take. I know we can't give. You've got to be careful not to give a diagnosis, but who's a candidate for just saying, listen, let's do some breath work. I don't know if you do anything else with the Schroth, whether some gymnastics. Obviously, gymnastic rings in my case have been amazing to just really start understanding and building the body, right? But like, when are you saying, okay, let's try these, the breathing, the braces, and when are you saying it's time, for surgery?
So there are extremes to both situations. If I see, for example, a 10-year-old child who comes in with an 80-degree curve or a curve even above 50 degrees, I know that the chance of them having to have surgery at some point in their life is extremely high. And the longer I wait, say if it's especially a thoracic curve, the longer I wait, the higher the risk of them needing a surgery into their lumbar curve is going to be high. And I would hate to fuse a teenager down to the lumbar spine because it takes away the rest of the body mechanics, or at least changes it in ways that we don't even totally know yet. And that's one of my passions, is to study that actually. So, for example, I'm working on a research project that shows that changing your, for example, L12 lordosis degrees from fusion causes a kyphosis of the lower lumbar spine where you're not supposed to have any kyphosis, and which then leads to later degeneration in life. So it's a very nuanced thing to, I guess, answer your question, but almost always I'm offering the options. And it is very rare in these cases, if I see an extreme curve in a very young child, they're getting surgery. Or if I see a moderate curve in somebody that's skeletally mature, they're almost never getting surgery unless they've tried all these other things and have failed it. So that's the easiest way to sum it up without going into numerous examples.
If you're saying let's wait and see, is there things that you're provide? Are you equipped? Is that your role to provide things and programs for them to do while they're waiting and seeing?
1,000%. I think it's malpractice not to. It is. My title is orthopedic surgeon, but I'm a doctor. Just because I'm a surgeon doesn't mean I need to operate. I think, and I think the whole community in the pediatric, at least the pediatric orthopedic world, is heading that way. We're not treating people just based on X-rays. We're getting the whole family into account. There's all these decision-making tools that we've come out with, and apps where families sit down with the physicians and sometimes a mental health provider, and they say, what is the priority here? Is it to preserve motion? Is it to avoid surgery? Is it to have a straight spine cosmetically? And you put it in onto all these apps and it spits out what the ideal answer is. And the family doesn't have to choose that, of course, but that is a case where it helps them make an informed decision. And where this has been most useful is for a kind of newer surgery that we're doing called vertebral body tethering, which is supposed to be a growth modulating and motion preserving surgery. Okay, so
Interesting. Is that the magic system?
No, the magic system still rods and screws that goes in the back, and it grows with the child, but it's still rigid. It takes away motion. It still ultimately goes to a fusion. The tether surgery, you're going through the side, so either through the chest for the thoracic spine or through the abdomen for the lumbar spine. And you put in screws and a rope on the convexity of the curve. So the idea is as the child grows, the convexity doesn't grow as much and the concavity can catch up. And it being a rope, it's flexible, so it gives you more motion than a fusion would. But the time frame to do that is
Interesting.
limited, obviously, if you want to use it for the way it's indicated to be used for.
Interesting. I want to continue with that, but let's just to wrap the other one. Like during the wait and see, what's currently being suggested by orthopedic surgeons during that wait and see?
If they're skeletally mature, we don't offer the brace because I don't believe that it works, and I think it can actually have detrimental effects on the whole posture and muscle control. So the main things that are being offered from my standpoint and my partners here is Schroth or some sort of scoliosis specific exercises. We're big proponents of things like yoga and things that allow you to have mind-body control outside of just a therapist telling you this is how you need to move your body. And overall, general, just physical activity is a very big thing because I found, and you probably found the same, is almost every patient with scoliosis that comes in has severely tight hamstrings, and their psoas is typically contracted, and these things together just put undue forces on their lower lumbar spine, which should not be there.
Yeah, the internal brace that our bodies form to deal with this. How do you, so do you have something in particular you approach for that or suggest for that?
I send them to my trusted colleagues in physical therapy or chiropractics who are much better equipped to manage it.
Okay, nice. Okay, so then going to where surgical options that we're at, because yeah, I always had that in my mind at 18, like shit, these Harrington runs are like they've been around for 50, 60 years, right? Like I was like, whoa, like that is a extremely rigid contraption to have in your spine that you're dealing with. Oh man, like that thought of that. So I was always like, if when it comes down to it, 20, 30, 40 years ahead in the future, I'm sure we'll have some better tech. But even at this point, like I'm still putting it off like another, let's say 30 years where I've got to get serious about gravity. I got to accept the consequences that gravity is going to keep on going. And I want to keep on going too. So I'm going to be open to the tech in 20, 30 years. Let's review what is it now and what do you see it going in the future?
Yeah, regarding gravity, I used to have a mentor in training who's one of his favorite things to say is life is a kyphosing event. So as you go, we just slowly bend forward. So surgery, right? So the Harrington rods, if you were offered this years ago, they're probably still doing that. So the problem with that thing is, although revolutionary at the time, is it's a straight rod. And as your spine's not straight, right? Like front to back maybe, but side to side, you're supposed to have natural lordosis and kyphosis and lordosis and pelvic incidence. So if you put something straight back there, sure, it might stop the scoliosis from getting worse, but you can't walk around with a straight spine, at least not for many years. Then they came out with hooks and rods that go in rather than just a straight rod. We started bending the rods to match the contour of the spine, so restoring natural kyphosis, restore normal lumbar lordosis. And then we started realizing there's no such thing as a normal lumbar lordosis or normal thoracic kyphosis because it's completely dependent on your lumbopelvic balance, right? So where your head sits above your thoracic spine and above your lumbar spine and above your pelvis is different for every single person. So you can't just take one big algorithm and say, hey, Arun needs 55 degrees of kyphosis, so I'm going to bend the rod to 55 degrees and give him that. You could be totally screwing me by doing that, even though you think you've done a great job and restored my kyphosis, which in scoliosis, you're typically hypokyphotic. But anyway, the surgery we do now is usually pedicle screws. So screws go into each of the bones, and we do osteotomies where we cut the bones and ligaments, just straighten out the spine and actually derotate it. That's a totally new thing we're doing in the last 5 to 10 years. Before we used to just put the screws in, put the rod in, and allow the rod to make it straight because it's a rigid rod. But now we're individually rotating each vertebrae using those screws as anchor points and turning the entire thing so that you're left with a straight spine or as straight as safely possible in a three-dimensional way, not just in two dimensions, not just in one dimension years ago. So that's a typical spinal fusion surgery or posterior spinal fusion. The other method, which I mentioned, was the tethering surgery, which is called anterior vertebral body tethering. So you go in the front of the spine. And this is supposed to work in children who have growth remaining. So it stops growth on the side that's grown too much and curved. So if your spine's curved this way, you put the rope on this side so this side doesn't grow so much and this side grows. We're still learning about it, and if you do it in the right patient at the right time, it seems to be working beautifully, but it's new, so it's going to take time. And people are, I think, being very careful and thoughtful about how to do it in most cases. And then you briefly mentioned the magic rod. So in really young children, we really didn't have options many years ago. Or we would put in screws and rods and they would go back to the operating room every 3 months and we'd have to manually lengthen them so they gained some height and chest wall height for the lung to develop. But these magic rods, you implant them once, and then every 3 months they come to the office and I put a big magnet on their backs, and the magnet lengthens the rod internally. And it has been, in my opinion, one of the biggest advances in spine surgery in the last 10 to 15 years.
A magnet that extends the rod.
The magnet, yep.
Can you have
So the rod itself has a magnet in the middle. So you put so say a 6-year-old comes in with a severe scoliosis that you can't brace, therapy's not going to work, nothing. It's just horrendous, right? So you put in screws at the top as anchors, screws at the bottom as anchors, and you connect the rod in between it. And just doing that will straighten out the scoliosis some. But as the child grows, the whole middle section is untouched, or technically untouched. The rod's kind of laying on the bone. So that part can still grow. So the magnets inside these rods respond to an outer magnet that we place, which induces like a rotational force on it that allows the rod to expand.
Amazing.
Really neat, and it avoids the surgery for the patients every 3 months. And of course, every technology has its difficulties, and when you have two metals rubbing on each other, people worry about metallosis reactions and ions in the bloodstream, and we haven't found that to be a problem yet.
Okay. Anything coming down the line? Any exoskeletons? Maybe like a wearable kind of exoskeleton? I'd enjoy a shirt that kind of just really promotes that breathing. And you mentioned in the one of the first surgeries, or I guess the primary surgery that you're doing at the moment, which is including that rotation of the spine, especially in that rib cage. At least for me, having that hemivertebrae, I've got like a rotation in the middle going on. So I breathe into my concavity, and I am encouraging that rotation with my breath. So that's amazing to hear, because that is something that the Schroth method did address, but then wasn't really in the surgery, it sounds like, as much. So
I think we learned
Yes.
that from the Schroth method and the other scoliosis-specific methods. I think it makes a very big difference in the three-dimensional way. And you can see the difference in the rib hump as patients are undergoing these surgeries and you're doing it, right? The spines that are rotated this way, when you take them back this way, it changes everything about how much stretch those nerves are feeling, how much stretch the spinal cord itself is feeling, and how much stretch the blood vessels and muscles and everything. I think it changes everything. And as far as things coming out in the future, I think artificial intelligence and machine learning are going to be the future for us, at least in the short term. And we're already taking that into account. Like I mentioned, every patient's different, right? I can't just put the same rod into every patient if I'm doing a spinal fusion surgery. But from a surgical standpoint, we're using all this information that we have, which is a complete overload anyway. And we, a company that does this, took a huge sample of normal non-scoliotic patients and measured how the spine should look when you correct a scoliotic patient. And they use AI to pre-contour the rods for us, and they mail it to us in that way. When we put it in, it provides what the spine should look like for each individual patient. Then as far as conservative things, I don't know of any wearable like shirts or things, but I have spoken to a couple of folks out in California who are working on devices that you place on your back that measures in a three-dimensional way how you're standing and how you're holding yourself. And it is unbelievable stuff. It's still very early in the process, but if you can provide something that the patient can see real time that, hey, I'm not standing right, I'm not doing what I was taught in my therapy sessions, and I'm just slacking off here, and it shows it to you, then that in turn, over time, I believe, and I think it's a common belief, it changes the mind to body connection and allows people to take that into consideration and just carry themselves better.
Yeah, at the moment, I guess the leading tech for posture correction is those necklaces that kind of measure this kind of movement. It's okay, but yeah, for me, as someone who is on this corrective kind of journey, it's got to include the breath. And I've looked at some of those chest strap monitors to be like, okay, it's that could essentially measure that we're breathing in the right places. And especially with the Schroth method we learn, we want to breathe to the side of the concave to create the space to de-rotate. Having some type of vibrational or tactile feedback there. You know, if my breathing is slowing down in that area, just some reminder to get that breath back into that corrective method, I think would be an amazing.
That would become second nature, right? If you do it enough, your brain's just going to know, right? Like in surgery, for example, I just know what the next steps are. I don't even have to think about it because we've done it enough. I used to be a swimmer growing up, and there were times we were swimming laps or practicing. I wouldn't even think. It would just happen because you did it so many times.
Yeah. The spine is like a spring, right? Is that like what it's really been designed to do?
100%, yeah. Spring for suspension, corkscrew, whatever.
Let's go a layer deeper into the nervous system, which I think I would love to see get more attention as well, because a lot of it's about the spine and the correction of the spine itself. But then we have our brain, which is sending information through our spinal cord, which goes directly in between our spine or in the middle of our spinal column, and sends information and sends instructions. And some of them are like they're just automated, and some of them are conscious, and we're sending intentions and telling us to sit up or to slouch, to do different things with our body. So some are there inherent, and some of them where we can decide what to do. How does the spinal cord play into everything we're doing? And does it, when you're going inside, obviously that's one of the most sensitive places that you got to keep an eye out for. So how do you describe the spinal cord and the nervous system with what you're doing?
Yeah, I think it plays a huge role, and I think we don't totally understand it yet. But many years ago, people started describing the etiology of scoliosis as a spinal cord issue. And I mentioned before, I take care of a lot of children with syndromic conditions. Where I see a lot of scoliosis, for example, is children who have something called a tethered cord. So your spinal cord ends usually at L1, maybe L2, into what we call a conus, and then that conus turns into lots of little nerve roots, and it's not supposed to be attached any lower than that. But in some children, there's a weird attachment that extends much lower or much deeper, and I feel, and we know that those attachments hinder the spinal cord growth, so your spinal bones have to make up for that by curving, right? Your spine bones can't keep growing, and you have a limited size of a spinal cord, otherwise you'll go paralyzed. And we've seen releasing that, and this is another big research project we're working on, is releasing that tether or detethering procedure improves not only nervous function in some of these kids, but improves their scoliosis. So there's so much more to be learned, but to say that there's not a connection would just be false.
Yeah, and that's something I came across as well, which was asynchronous neuroosseous growth, which is the disproportional growth between the spinal column and the spinal cord. You have this tethering, but I feel like I don't think I had the actual tethering, but I did have a pretty traumatic event around 13 years old, near drowning accident. I had one leg on a rope in a river, and my other leg was getting jarred this way, and so I had quite a trauma to the groin, the hip area. And whether it's in that experience or in the months of just limping beforehand, I had quite a tightness in my hip that years later I remember thinking, oh, I'm just not as flexible in my hips. But I realized that might have created a chronic tension that might have even simulated that tethering. When I think about a nervous system that's trying to protect itself or trying to hold on, I imagine that tensing, that tethering effect can happen. And as I've integrated that kind of realization into my healing now, when I focus on relaxing the nervous system, especially during these Schroth breathings, and I'm holding, maybe I'm in traction, I've got the inhale, I'm inhaling into the correction, and then I'm exhaling. And as I'm exhaling, I'm sending these, I'm really conscious of the thoughts that I'm sending through my nervous system to integrate, create, to restore these neural pathways. And one of the most powerful messages to restore during that moment is safety. I have safe, I feel safe, I'm safe, I trust. Feel safe, I trust, and I let go. Because I found I've been letting go, and I can always go deeper letting go. And sending those instructions through my nervous system allows that elongation of the entire column, and the alignment happens. And it's freaking amazing. And I would love more people out there with this kind of curiosity as well in this area, because I do think it's a thing.
I am 100% on board. The idea of neuromodulation, neuroplasticity, we always learn and know that it's kids, right? That's why children like at 5 can learn 3 languages, no problem. But when we're 18 or 25, it becomes much, much more difficult. But it doesn't mean it's not there. You just work on it and you push it. Your nervous system, like any other part of your body, is something that you can work on.
Yeah, to retrain, to create new neural pathways. If we've had a neural connection that's just chronically tensed, and we've got this warping effect because our nervous system is just so tight, the spine hasn't been allowed to. I think it's at the core of a lot of potential healing for a lot of people.
Totally on board, man. That's awesome. Good stuff.
All right, we've done some good stuff here. I'm wondering what you would say to someone right now, because your time is very precious. I know that you're going into surgeries a lot now. What would you say to someone who's considering surgery? I think that's where a lot of people are. They're lost. They're facing a lot of mental pressure, as you mentioned, right? It's a very big decision to make at a very young age. Sometimes the parents are involved, so that can even complicate it more. How does someone even begin to think about this at that age?
Yeah, that's such an important question. I'll focus my answer more on the older teenager, and because children, I think, they truly don't know and the parents make it, but older teenager and young adult folks. So scoliosis, first and foremost, does not define any patient ever. So I tell them this every single time. It is just a small part of who you are. It doesn't change your dreams, your aspirations, or what you can achieve in life. And it is a very fixable problem if it needs to be fixed. So I tell them, and we'll use a classic example of a 16-year-old girl who comes in with a 60-degree right thoracic scoliosis. She's in 10th grade. She's a cheerleader. She doesn't want to disrupt her life. We say, that's okay. Go live out your life and your dreams and start doing something, because now you have this diagnosis. Don't ignore it. And you're too old for bracing, but that doesn't mean you do nothing about it. And that's what we used to say. You say, you don't have to do anything. It's just going to get worse. Come back and do it. A, this doesn't define you. B, let's get you into some sort of Schroth therapy or some sort of movement type focused exercise that allows you to better understand your body and the way you carry it. And then C, let's follow you closely to make sure this doesn't get out of hand. That 60-degree curve, say she comes back in a year and it's 90 degrees. Now we're in trouble. Now I can't just watch it anymore. So those are the 3 most things. And I give every patient my email, and they're welcome. If you're not over 18, you got to email me from your parents. They're welcome to be in touch and ask questions. And I give every patient the opportunity to connect with another patient who's been through this. And the last thing we offer is a second or third opinion for every patient, because we live in a completely interconnected world, and there's no reason to take one person's answer as the final answer.
Amazing. And then for that adult, that 30, 40, 50-year-old, they've been living with it. Now, when I went through, I heard that most adult scoliosis was not eligible for surgery. Is that still the case? What would you say to someone Hey, maybe they're starting to feel the effects of gravity. Maybe they're like, okay, I've ignored this for too long and it's starting to get in the way here. What are you saying? And which surgery?
She had the spinal fusion surgery.
Okay. Which is there a removal of the vertebrae?
No, you don't have
No,
to. If
no,
it's
no.
like in your case, if you have a congenital hemi, you have to remove it. But in her case, it was just an untreated idiopathic scoliosis that you don't remove the vertebrae, but you remove the intervening ligaments and some of the joints to loosen up the spine to straighten it more.
Okay. Yeah, obviously not diagnosis, but if you would say that it's an option to explore, even if I'm 39, moving the T10 hemivertebrae and then fusing from there with what type of.
I would have to see your X-rays, MRI, all that stuff.
Sure.
But typically, in a hemi, like a T10 hemivertebrae, causes kyphosis and scoliosis, and usually we take out that segment that isn't fully formed or fully segmented, that hemivertebrae part of it, put a cage in there to fill the gap, and then straighten out the spine as much as safely possible. Put in screws a couple levels above, a couple levels below, and a few rods to hold everything in place.
Like fixed rods or slightly curved rods?
They would be curved to match the area. So if it was a typical patient would have a fusion from about T8 to L2, that would, in most patients, T8 to L2 is a pretty straight segment. So those would be almost straight. But
And then the cage is to simulate the vertebrae?
it's to, when you take out the whole hemi, there's a huge gap left, and you can't just leave it because that's too much of a space for the body to fill in. And eventually it'll typically cause the rods to break. So the cage is supposed to be an additional source of stability and fusion. So.
Wow. Okay. All right. Yeah. It's been a while since I talked to a surgeon, so this is
Yeah,
extremely enlightening.
we did that on a 3-year-old who had an L1 hemivertebrae a couple of weeks ago, but he was losing function, so he wasn't somebody that we could just say, come back. You know.
Mm-hmm. Mm-hmm. Yeah, at this point, it sounds like it's getting safer, but I think for me, I've got full function. I'm really happy. I don't have, pains. It would be purely aesthetic. So,
Yeah.
I think I'm okay. I think I would love to get involved in some of these more wearable technologies. I know that AI is going to be a piece in this, whether even like a massage chair with AI that can understand your spine and start working it. I really think that's where it's going.
We have too much
I
information
guess.
and we don't know how to put it together yet. That's where we're really missing out on life here.
Okay, it sounds like things are going in a good direction. I thank you for sharing where you're at, and thank you for integrating all this stuff, because I know I can tell by the things you're doing, you're very beneficial for people who are coming across you, whether people went through the systems or surgery considerations beforehand. A lot of people have been left disempowered about what they can do. It wasn't an option. Now they're just on their own, but yeah, we're just getting the idea out there that there's a lot that you can do. So
Awesome. Thanks so much for having me, and keep up the good work.
all right. Thank you very much.